So it is as old as mankind. The first labor pain described in Eve. But even today, 2025, in the month of May, I can tell you every day we have patients where the mystery of pain we cannot unfold, we cannot describe. So even today, it is still mysterious. I'll just give you an example. Like these are some rituals or festivals which in our South India or maybe Thailand, Sri Lanka, these are very popularly done. So, what I try to tell you is that the concept of pain and its treatment is one of the most interesting and fascinating. That's why I told you that I get very excited speaking on this in the history of medicine. See what patients is. It is considered as a subjective experience. In fact, we didn't have even a visual analog score. There were no objective tools to quantify pain. We do have now the visual analog score and other scores, but still, more or less, I would say that historically as well as today, it's a subjective experience. So, as I said, my title would be Chronic Pain Demystified. Of course, it will be an approach to a patient with chronic pain, but demystified. Why I'm say so? That if you all know that, I'm sure you all know what is the word pain derived from. It's a Greek word, poena. Poena means penalty or punishment. So even before Christ, this word pain, which was derived from a Greek word, described pain as a penalty. Of course, we know even today, if you have pain, acute or chronic, it's suffering which you're having. So penalty or punishment. So that is the definition of the word pain. And I'm sure most of you may not be knowing it. That's why I thought I will tell you all. We all know that Eve, when she had a childbirth, she had labor pains, and it is all described in the old historical literature. So it is as old as mankind. The first labor pain described in Eve. But even today, 2025, in the month of May, I can tell you every day we have patients where the mystery of pain we cannot unfold, we cannot describe. So even today, it is still mysterious. I'll just give you an example. Like these are some rituals or festivals which in our South India or maybe Thailand, Sri Lanka, these are very popularly done. And you see this person walking on fire, no expression of pain, tongue piercing, no expression of pain. All these rituals are very, very, like recent. Last week only this ritual happened in Kerala and there was no expression of pain. What happens? We all know even a pin, if I have a pin prick, I get so much pain that I start shouting. But what happens to these people? We are still not aware. Like there are explanations that endorphin release or what not release happens and patients do not experience pain. But I can tell you, if people who have watched these rituals, they have told us that absolutely no remorse, no feeling, no expression of pain on their faces. So again, that needs explanation as what we see every day. So, what I try to tell you is that the concept of pain and its treatment is one of the most interesting and fascinating. That's why I told you that I get very excited speaking on this in the history of medicine. See, 322 BC, the philosopher Aristotle said that pain is perceived in the heart. So we had no inkling that pain is carried by some nerve fibers or perceived in the brain. Only in 1644, just about 400 years ago, that René Descartes said that pain is perceived in the brain. And of course, then in 1895, so 200 years, nothing came out, and 200 years, 250 years later, the specificity theory that there are nociceptors, there are nerve fibers which carry the sensation. Melzack and Wall, again, another 100 years, nothing happened. Gate control theory, which was again sort of put out of use, and multidisciplinary Bonica biopsychosocial model. So of course, we don't have enough explanations to a variety of chronic pain or acute pain syndromes which occur even today, and that is what we are going to discuss today and see any solution to them. Now, why pain as a symptom is challenging? In the early years, like when we started pain clinics and pain medicine, we had a lot of challenges. We have to believe what patient said. So it is pain as a symptom relies very heavily on self-reporting. What the patient says, I've got very severe pain, I have to accept it. And even today, I mean, this I'm talking 40 years ago, but even today, we have to believe what patient says. It is considered as a subjective experience. In fact, we didn't have even a visual analog score. There were no objective tools to quantify pain. We do have now the visual analog score and other scores, but still, more or less, I would say that historically as well as today, it's a subjective experience. Pain management, again, if you look at the chronic pain syndrome, mostly empirical, based on my experience, based on his experience. We do not have any consensus on the management of a lot of pain syndrome. Giving an example of fibromyalgia. I mean, even 20 years ago, nobody used to believe. Even today, there are physicians who don't believe that there is a fibromyalgia type of a syndrome. They say it's all in the brain and patient is perceiving pain, but he is not organically or pathologically suffering from anything. Pain is consistently inconsistent. That is what is very, very important. Consistently inconsistent. You may not have two patients with similar sort of pains describing their pain in a similar manner. So that is what it was 40 years ago and today. And sometimes to come up with like I have a patient with a radicular pain from back pain, and I think it's from a nerve compression, but I get an MRI, it's normal. So I am not able to explain anatomically that why he's having a radicular pain in a dermatome of L4, L5, but when I see the MRI, it's absolutely normal. So this was 40 years ago and even today. So these are some of the challenges which we everyday face. Now, as I mentioned, that fibromyalgia is one disease which is not visible. But if it is visible, this is what one patient has sort of drawn on her body. Female patient, she said that if it is visible, it is like this. You can see the red colored and the blue colored and the yellow colored areas which she experiences as severe pain, and this is not visible. This is And she cries that my illness is real. Please believe me, my illness is real. But 2025, I don't have an explanation why she has pain without any evidence of anatomical disruption or pathological disruption. So these are some of the questions which we have to answer, and I would request you, young physicians, to take a lead and discuss and do research to find out the reasons for this. Now, one important thing why we're talking about chronic pain, if you look at the global prevalence, we always believe that cancer, coronary artery disease, diabetes are the important causes of morbidity and mortality. But if you look at this figure, this is from United States of America, not from India, which says 26% point prevalence at one particular point. 26% of the global population at one particular time is suffering from chronic pain. So that big, much bigger than all these things together: the cancer, the sugar, diabetes, the coronary artery disease. So that's why there have been lots of editorials where they have said that pain as a global public health priority, and they have said that should be a part of any national health program, and we should give more money for research into chronic pain. Then, of course, other diseases also require research, but this is one important disease which requires a lot of research. If you just corroborate these figures to our population in India, 20 to 25%, of course, US says 30%, but 1.35 billion, 25% is 400 million population at one particular time is suffering from high impact chronic pain, which could be back pain, musculoskeletal pain, cancer related pain, neuropathic pain, arthritic pain. So it's far higher than other diseases, and we have to cater as physicians, as any specialty people to this large number of population. So huge number of population, and very difficult to do a prevalence study in a big country like India. But in 2014, we did one attempt. 2013, we did one attempt to find the prevalence rate. Very difficult because you have to sort of do a telephonic survey or you have to ask through emails. So this was like in 2013 when internet was not very popular. So we used to telephone them, and we telephoned about 2.5 lakh people across the nation, from northeast to south to north and to west, and we asked a simple question: do you suffer from any pain beyond 3 months? If the answer was yes, they were kept as a part. If the answer was no, they were eliminated. So we got about 1.25 lakhs people, and out of which about 60-70,000 told their details, and we were surprised. Of course, this study showed about 19% prevalence of chronic pain in India, but the treatment practices which we were alarmed was that most of them were taking NSAIDs for more than 6 to 9 months. They were once prescribed NSAID and they thought that this is the only answer, and they continued to take NSAIDs for a pretty long time. So very important to do prevalence studies, but big country. So I think the younger generation has to do something to get better uh, prevalence rate. And then if you look at the WHO statistics, which says 1 in 10 Indians will develop cancer during their lifetime. This is very alarming. Huge figure, I would say. 1 in 10 Indians, 1.36 billion. So you can imagine this will run into millions and millions of patients. But more important than that is that of these 10 Indians who will develop cancer, about 70% will develop cancer when they are already in the advanced state. And for them, the only answer would be pain management. So again, it boils down to devising pain relief strategies for such patients like cancer pain patients, where no treatment would be possible, but it will be only the palliative care and the pain management. So that's another important thing which we have to remember when we are talking about chronic pain in general. Cancer pain being a very important entity to this. Now, there is a paradigm shift to chronic pain. Earlier, we were declaring it as a disease, as symptom of a disease, but WHO, when it declared in 2005 that this should be a disease state of the nervous system, persistent chronic pain, any pain beyond 3 months, not just a symptom. So, if you have a patient with chronic pain of beyond 3 months, you have to consider it as a disease entity. Why disease entity? Because chronic pain has a bearing on lots of body organs. It can disturb your cognitive functions. It can cause increase in your cardiovascular activity. It can disturb your renal functions. It can disturb your liver function. So if a symptom can cause so much of affection on your body function, then it cannot be just a symptom. It has to be a disease. So very rightly, WHO declared chronic pain as a disease entity, not just a symptom. And then the charter also mentioned that the relief of pain should be a human right, and that's a very significant thing which they said. And if we as physicians cannot violate a human right, we have the responsibility of taking care of patients who are in acute or chronic pain, because that's the right of a person, that he should be relieved of pain. So this is a new definition which has come in, and every I mean, like, the researchers try to find out what pain definitely means or generally means. So the definition which was given about 4 or 5 years ago mentioned that it's an unpleasant sensory and emotional experience. So this one, I mean, like, of course, we had an older definition which also mentioned emotional, but as a beginner, I'm trying to tell you that emotional experience is one which we always overlooked. We know it's a sensory experience. You block the nerve and pain will go away. No, no, no. It never happens like this. What about the emotional experience which the patient is having because of the chronic pain? The cognitive, behavioral deficits. We have to look into that. So that definition says emotional experience associated with or resembling that associated with actual or potential tissue injury. So that perhaps tries to explain the nociplastic pain, fibromyalgia, irritable bowel syndrome, pain, where there is no injury. So it says resembling that associated with actual or potential tissue injury. Of course, we all know whenever there is a tissue injury, patient experiences pain. But without a tissue injury, patient experiencing pain, yes. Lots of syndromes we have: myofascial pain, fibromyalgia, and huge other types of pain syndromes we encounter in our daily practice, where there is no injury, but yet patient is experiencing pain. When I said no injury, I would say there is no inflammation also. So this definition was divided 4 decades after the first definition came in. This was the first definition associated with actual potential tissue damage. This is the 2020 definition. But there were some pain notes which were very important. Pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. Very, very important. We look only it as a biological, we don't look at it as a psychological and social. Pain and nociception are different phenomena. Very, very important. So if you're hurt, your nociceptors become active. That is not just the pain. Pain cannot be inferred solely from activity in the sensory neurons. Through their life experiences, individuals learn the concept of pain. A person report of an experience should be respected. So don't laugh at the patient. Whatever, I mean, like he's saying, you have to believe it. He's saying anything which does not sort of go into the anatomical boundary, but you have to believe it. Very, very important. So don't laugh at any patient. It is crazy for you to sort of make it out, but it is to be respected because what he says, it is his experience and you have to respect it. Although pain usually serves as an adaptive role, it may have adverse effects on function. That's what I said. And verbal description is the only one of several behaviors to express pain. So verbal expressions are very important. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. So if he is not verbally expressing, don't think that he is not suffering from pain. So this is very important, and I would request all of you to go through this charter of ISP 2020 to show into this. So I would say now in 2025, we are moving towards a new classification of pain. We always believed in a neuropathic pain and a nociceptive pain, which is like because of injury, neuropathic pain because of the nerves. No, we have now 4 categories of pain. This classification tries to explain the pain in a better way, better pathological classification. We all know the physiological pain. Whenever you have an injury, you cry. Nociceptive stimulus, pain, surgery, trauma, etc. Inflammatory pain, this is different than nociceptive pain because the mechanisms are totally different. The mediators are totally different than physiological pain. So earlier we were classifying nociceptive pain also as an inflammatory pain, but now it is different because the mechanism is different. So osteoarthritis, spondylitis, rheumatoid arthritis, ankylosing spondylitis all come under inflammatory pain. Neuropathic pain, we know there is a nerve lesion, diabetic neuropathy, postherpetic neuralgias, radiculopathies, and of course trauma causing injury, neuropathic pain. But this very important group which has come now is the dysfunctional pain. Fibromyalgia, irritable bowel syndrome, complex regional pain syndrome, and myofascial pain. So dysfunctional pain, or also called the nociplastic pain. Why we call it nociplastic? Because we think that there are some plastic changes which have taken place in the dorsal horn of the spinal cord or in the brain, which leads to this, such a resistant plastification of the impulses in the spinal cord that they are very difficult to remove. So that's how you explain these very, very resistant syndrome. Day in and day out, I see a number of patients of fibromyalgia. You give in any drug and they don't respond. So lots of multimodality efforts have to be done, and that's dysfunctional pain or nociplastic pain. So this makes our pain explanation better than as compared to nociceptive and neuropathic pain. Now coming to the clinical part, the assessment of chronic pain. As I mentioned, that there are lots of biomedical and psychosocial and behavioral factors which shape the myriad, which shape the chronic pain, not just a nociceptive stimulus, not just a nerve injury. So patient beliefs, expectations, mood, context, responses by significant others, they all contribute. So when you are assessing pain, you don't have to assess just the visual analog score. That doesn't make any sense. You may say 8, 9, but these important things, every domain has to be assessed. So very important that you have to assess the behavioral aspect, the cognitive aspect, the pain aspect, the disability because of pain, the quality of life because of pain. Everything has to be assessed, not just the pain intentionally. Functional abilities, beliefs, his expectations, emotional distress, everything has to be assessed when you're doing. I'm not going into the details, but there are lots of questionnaires, lots of scales, lots of methods by which you can do it. We may have a separate lecture on this, but very important that when you're assessing, you have to be assessing in a very, very important way. Now, one of the very important missing link in chronic pain management now, I'm sure all of you know about it, but this is one very important missing link which we always have to stress, that we have been treating pain as a biomedical model. No nerve, block the nerve or give painkillers and everything should be okay. But now we have moved from the biomedical model to biopsychosocial model. And that has made managing pain much easier for us. That may not be sometimes a possibility in real case, in real clinical scenario, but obviously biopsychosocial model has to be sort of agreed to whenever you're treating acute pain. So this model describes chronic pain as a complex, dynamic interplaying among biological, psychological, and social factors. So it has a strong impact on the patient experiences and treatment outcome. Now, we used to say pain threshold. I have a very high pain threshold. I don't experience pain. It is not that. It is the pain experiences which he has had in the past that makes him stronger to tolerate pain, and no pain experiences which the person had not in his life, and he cannot tolerate even a VASC of 2 or 3. So effective pain management requires integrated multimodal biobehavioral approach early in the management of chronic pain. And this is very, very important. Clinical, little difficult, but you have to make efforts so that this aspect is incorporated in your holistic management of pain. And we always use the word holistic because it is important that by this medications alone cannot help. So exercise, procedures, sleep. This is what we normally do. But cognition, emotion, behaviors, attention, then social role, family, work, all these important things. Whether he's able to work properly, what is his quality of life, what is his family sort of helping him or not helping him, all these are very, very important. And unless you follow this model, it will be difficult for you to have a holistic approach to chronic pain. So I'll just give you an example of back pain, which is the commonest back and neck pain, perhaps. I cannot go into all the diseases, so I thought I'll just select this challenge of back and neck pain to give you how comprehensively you have to assess, examine, and find out the cause. Finding the pain generator is the most important thing. And how do we do it? So the various important causes are these in your OPDs or in your clinics. You may be having these myofascial pains, disc bulges, stenosis, fractures, infection, tumors, spondyloarthropathies. So a varied number of reasons for back and nerve pain, and these are some of the commonest, as I said, mechanical, neurogenic, non-mechanical, referred, and others like fibromyalgia. Very important to understand that these back and neck pains are not just nociceptive pain. We always used to believe it in the past. That's why we used to put them on anti-inflammatory and tell them exercise, exercise, everything will be okay. But then the detailed clinical examination revealed that these are heterogeneous disorders. Simple neck pain of 1 or 2 or 3 months is not a simple nociceptive pain, not a simple myofascial pain. It is a mixed type of pain where there is an element of nociceptive, neuropathic, and also central sensitization. So the longer the duration of pain, there is a process which sets in which is called the central sensitization. So very important that for an efficient treatment in daily practice that we have to categorize this pain. Simple back and neck pain. No, definitely not an inflammatory pain alone, not a myofascial pain alone, not a nociceptive pain alone, but it is a mixed. Because if you do not know that this is a mixed pain, you will be only sort of managing one component of that pain and you will not get the desired result. So holistic management sort of tells us that you have to first find out what type of pain syndrome it is, dysfunctional pain or central sensitization, neuropathic pain, and nociceptive pain. Chronic, acute, and back pain have been acknowledged to have multiple potential. That's why we call it as a mixed pain. These are so most important agenda is what is the algorithm approach in clinical assessment. Very important. Again, come down to the basic. Very, very important, please. Appropriate history taking, detailed neurological examination, then appropriate imaging, decision making, diagnostic, and therapeutic intervention. Then don't leave it at that. Most important thing is the rehabilitation. So pain management doesn't stop at reducing pain, but you have to put him back to what he was doing earlier. So that is the algorithm. Starts with history. Healing begins with history. History is very, very important. 90% of your diagnosis you can clinch with a good history. And I am telling you from my personal experience that with a history, we have been able to tell you that this patient has a hip disease or a spine disease or whatever, like a knee. Just in the evening we saw a patient, chondromalacia patelli. Only on examination you could find out it's chondromalacia patelli. So don't jump at the MRIs, don't jump at the investigation. Please do this important thing, history taking, examination, etc. You may feel bored listening to me, but very important, these are very, very important aspects if you want to become a good physician. Focus history, I'm not going into the detail, but everything, morning stiffness. Supposing a patient says morning stiffness, what it could be? It could be an infection, it could be an inflammation like ankylosing spondylitis. So everything is important. Bladder and ball could be a cauda equina. So every history point gives you some clue to the diagnosis. And at the 15 minutes history, I'm sure 90% of the diagnosis is with you. Job profile, trauma, previous history, everything is important. Cancer, I mean, like there are history for specific conditions. I'm not going again into the details, but you have to know it. I'm not able to move the slides, Barkha. Yeah. So based on the history, you will be able to find out the red flags for the lower back pain, the yellow flags for this. All these are important to tell the patient also. The red flags have to be told to the patient. That if you, supposing I see a patient in the evening who has come to me with 2 days of back and leg pain, I have to ask this history and I have to tell them that these are the red flags. If it happens, please come back to me immediately. And similarly, red flag, the yellow flags, the psychosocial problems in acute phase and slow progress to recovery may be due to undetected or unrevealed psychosocial factors. So you are worried that I've done everything, I've done a block, I've given my medicine, patient is still not getting relief. The reason may be these yellow flags. So you have to evaluate and take care of these yellow flags. And then again, if you don't have these elements in your OPD or in your pocket, you're not a good physician. You have no liability to touch a patient with pain. Hammer and everything else are very, very important elements to find out the motor elements, sensory elements, autonomic elements, and deep tendon reflexes. Please don't mind it. This is basic, but I'm highlighting these basics because sometimes in the course of being seniors, we tend to forget the basic thing. We tend to just look at the MRI and confirm the diagnosis and even start the treatment looking at the MRI. No way. You are not treating MRIs. You are treating patients. Please. So give importance. Again, remember the art of these reflexes. Very, very important. These reflexes are much better than an MRI. If you look at these reflexes, you will be able to tell what level of cervical nerve is getting pressed and what all motor damage it has already given. So, by history and examination alone, like if his patient have history of back pain, back dominant pain aggravated by flexion, it's a minor disc, extension, it's a facetogenic pain, leg pain, flexion, nerve root, walking central stenosis. So you can have a fair idea of the diagnosis. That's why I laid more important. And why we sort of lay stress on these pain pathophysiology, because they can help us in guiding the pharmacological therapies. If it is moderate to severe pain, you may use opioids. If it is like a pain which is because of neuropathic central sensitization, you have to give alpha 2 delta ligands or antidepressants. If it is mild to moderate, acetaminophen, non-selective NSAIDs or a nociceptive pain, these may be sufficient. So finding out whether nociceptive or neuropathic or central sensitization can guide you to an appropriate pharmacological therapy. So a general approach to pain management has to be a firm-fisted approach. It is not to be an approach of sort of conservative approach. It has to be a multimodal approach. It has to be a holistic approach. And all the modalities, with just the 9 broad categories, not one modality, but you have to combine like a good sleep, managing the stress, lifestyle management, pharmacotherapy, physical therapy interventions, biofeedback, complementary therapies. Of course, in India, we use complementary therapies too, and surgical therapies. So, any one of them or mixture of these have to be used to manage acute pain. Cognitive behavioral therapy. You have to learn as pain physician. You cannot, in India, I can't refer my patient to a psychologist or a psychiatrist. You know all. Reason being that if I send a patient to a psychiatrist, the patient is never going to come back to me. He would think that this doctor also believes that everything is in the mind. So you have to learn the art of the counseling, learn the art of cognitive behavioral therapy, These are small, these are not very difficult things. And of course, you have to prescribe some antidepressant and anti-anxiety. That's the unfortunate thing that our patients don't like to go to. If there are psychologists here, please, they don't like to go to a psychiatrist and psychologist because they don't want to sort of consider their pain as a psychological pain. But obviously, we cannot tell them that 30% of your pain is because of the cognitive behavioral deficit. So this is important. But as a pain physician or as a general physician or as a surgeon, you can definitely learn the art of cognitive behavioral therapy and help the patient out in various conditions. So there have been a lot of advances in pharmacotherapy of pain, like I'm talking about last 30 years when we didn't have anything, and we had this like anti-selective tricyclic antidepressants, selective SNRIs and SSRIs, and everybody now uses these uh, duloxetine and other drugs very very commonly. COX-2 inhibitors were not there; they have come in patches, topical analgesics, NSAIDs, lidocaine patches, and these buprenorphine patches, fentanyl patches. They're all like 10 years, 15 years old. Triptans for migraine management, opioid agonist combination like tramadol, tapentadol, sublingual opioids we have like buprenorphine. We have now other things like uh, CBD like cannabis. We have gabapentin, terpenoid, capsaicin patches, and of course for the inflammatory disease we have the TNF alpha 2 inhibitors now in plenty and available very cheap too. So we have lots of pain medication. Again, in this another 5 minutes, I cannot sort of go into detail, but we'll think about some separate topics for this. Lastly, about the interventional pain management, because as a pain physician, this is my very important specialty, very important component. So we have to regularly update. So it not only helps me in managing pain, but also helps me in finding the cause of pain. So if I do a nerve block to find out the reason for the nerve block, I will be able to find that this is the pain generating structure. So we have been in the past 40 years, we have been adding on the intervention. The technology is improving like in any other specialties. So we have, whenever given the opportunity, we started doing like the kyphoplasties. We started doing newer pain like radio frequency ablation. This is a Gesserian ganglion block. This is genicular nerve RF, endoscopic discectomy. So these all these non-invasive interventions or minimally invasive interventions we have been using for pain management. As I said, not alone, but along with other therapies which I mentioned. So like stellate ganglion block in patients with sympathetically mediated pain. Ultrasound came in 10 years ago. We started using ultrasound guidance for pain, where we can exactly localize the various musculoskeletal structures and find out the cause of pain. Radio frequency ablation came in a big way, and we have we before that neurosurgeons were using it, but since 1998, we as pain physicians started using radio frequency in managing Gesserian ganglion. But now there are extensive usage of radio frequency, like in pain management, like this. It's a normal norm in pain clinics now. Like this is genicular nerve RF being done. We do peripheral joint neurotomy. So patients who are not fit for surgeries, end stage osteoarthritis, hip, shoulder, joint, we can denervate the important nerves which supply the joints, and they can be very useful for eliminating pain or for giving pain relief to the extent of 80 to 90%. So these are all new things which are coming in, and we are adopting them. Cooled radio frequency came in when we do genicular nerve ablation. Neuromodulation. So when everything else fails, we start using this neuromodulation technique, which is putting in an intrathecal pump for baclofen in spasticity, for morphine for managing cancer pain. Spinal cord stimulation. Again, these are the stimulating electrodes put in the dorsal horn of the spinal cord and connected with a pulse generator. This is used for failed back surgery syndrome, for complex regional pain syndrome. Just giving you an overview. Dorsal root ganglion stimulation now coming in, sacral nerve stimulation, which is coming in only not only for pain management but also for controlling the urine. If the patient has incontinence, you can use this technique for taking care of their incontinence. So we always tend to expand our horizons. Regenerative medicines in terms of PRP, it's a routine now, and we are using extensively every day. PRP, adipose tissue, bone marrow concentrate for for their stem cells for regenerative therapy. And in fact, in years to come, regenerative therapy would be the most important component of pain management, because we are not sort of destroying structure now, we are regenerating structure. So replace, regenerate, revive are some of the new terminologies which have come into pain management. So we are beyond the destruction. We don't want to block the nerve, we want to regenerate the cartilage, etc. Then, of course, migraine, as you know, is a very important uh, disease syndrome affecting about 5% of Indian population, 7% of US population. So, if the migraine doesn't respond to drug, we use Botox injection for managing that. And then, of course, for very centralized pain syndrome which don't respond to anything, we have started using IV ketamine infusions, which is one of the most powerful NMDA receptor antagonists. Unfortunately, we don't have any oral drug which is available as an NMDA receptor antagonist. So ketamine infusions, which we're doing routinely for last almost 15 to 17 years in these resistant fibromyalgia, in the resistant CRPS, and in nerve injury patients. Of course, very important that if there are some good things in our indigenous system, you must utilize them. So somewhere down the line, we are trying to incorporate our Ayurveda in some of these back pains, which are non-specific back pain, no cause, but patient is not getting any relief. So we are incorporating, but not to a big way, but yes, we should do it. And yoga, of course, that is very important. There is a clear evidence that yoga helps, and particularly in patients with fibromyalgia, yoga really does wonder. Swimming and yoga. And these are two things which we are adopting for our patients, and we are getting good results too. Future of pain medicine, of course, we have digitalized assessment and monitoring. Patient sitting at home, but I am sitting in my home, will be able to see the response of my medications through a digitalized assessment. Regenerative therapy, of course, big way, and gene therapy. Of course, gene therapy is also in the pipeline, and maybe in few years to come, gene therapy would be one area where chronic pain can be easily managed using gene therapy. So in the end, we have about 20 minutes left for interaction, maybe 25 minutes. Pain medicine is all about a smile. What you want is a smile on your patient's face by doing your holistic management of pain. But I would always say that pain management is not just a science, it is more of an art. So, two patients with similar problems, with similar intervention may not respond. One patient may respond, one may not. So it is an art. You have to learn. Why I say art? Because you have to develop a rapport with the patient. You have to have those interpersonal skills so that you can sort of influence the patient. You can have a suggestibility to the patient. You can impact his life by suggesting something. So it is not all medicines which are going to work. It is your compassion, your empathy, which towards the patient, which is going to do wonders. So always remember, you have to learn this art. Science very easy. Give drugs, put needle, everything gone. But the art is difficult, because that is what is going to give you holistic relief in pain. Thank you so much. We are open for questions now.
Thank you so much for that illuminating presentation. You have really redefined our understanding of pain once again. So we do have a lot of questions that are coming up, sir. So I'm going to be taking the questions and I'll be highlighting it on the screen for you as well. Okay. So the first question on your screen now. So Dr. Benjamin says, patient presents with pain, right foot area alone. Patient is a known case of diabetic neuropathy, loss of touch sensation in soles, but persistent pain in dorsum of foot. Relief for a week once using tramadol and thiazolidine, but started again after 1 week. But we can't prescribe this tablets for too long, right, sir? So any suggestions?
So basically, if you're saying it's a diabetic neuropathy, and as the history also suggests that there is a pain and loss of sensation, touch sensation, so it's a clear-cut case of diabetic neuropathy. So tramadol is one drug which can relieve pain, but there you have to prescribe like gabapentinoids, like gabapentin, pregabalin, along with SNRIs or SSRIs like duloxetine. So that would be more specific treatment rather than tramadol alone. Tramadol is just a specific treatment for pain. But if you want to take care of the neuropathy, you have to continuously for a long time give drugs which help in neuropathy. And a number of drugs like duloxetine, as I said, pregabalin, these are preferred drugs for diabetic neuropathy. So those would be important rather than giving tramadol or thiaclocicine. They can be added for a shorter period, but for a longer period, I think more important are those drugs.
Right. So, moving to the next question from Dr. Ravi. What modality of treatment can cure post-herpetic neuralgia permanently?
Well, this is a very, very difficult question, and we encounter lots of patients with post-herpetic neuralgia. So the definition of post-herpetic neuralgia has changed. In the past, it was like 28 days after developing post-herpes that patient develops pain is called post-herpetic neuralgia. So I have eliminated post-herpetic. I call it herpetic neuralgia, which starts from day one of herpes. So you have to be treating herpes neuralgia from day one. Even if the patient complains or not, start gabapentinoid immediately. Tell the dermatologist, please start gabapentin on day one. Permanent cure, difficult to say, because obviously only 50 to 60% patients develop herpetic neuralgia, 40% don't develop. They are permanently taken care of. But once it develops, it's a damage to the fibers, nerve fibers, the neuronal sheath and the neurons. So that damage can regenerate, but it takes long time. So I would say if you say cure, I can't use the word cure, but manage, yes. So management, there are a number of drugs we all know, gabapentinoid, SNRIs, SSRI, tramadol. Then if it doesn't work, then we go for nerve blocks. Supposing it's in the ophthalmic division, I do ophthalmic like supraorbital and supratrochlear nerve blocks with local anesthetic repeatedly. I have gone to the extent of putting a spinal cord stimulator too in a patient with post-herpetic neuralgia. But it depends on the duration of hepatic neuralgia. If it is more than 3 months, it becomes difficult. More than 6 months, very difficult. If the patient comes to me after 1 year, I will try my best. But curing, definitely I would not say. Managing, definitely I can do. We have capsaicin patch which can be applied, which can give considerable 3-4 months relief to the patient. Lidocaine patches also can be used for managing pain.
So, next question from Dr. Patel, drug of choice in fibromyalgia and how to manage dysfunctional pain syndrome.
Well, fibromyalgia, as I said, is a multimodal, multifaceted management. So not just drugs, but the cognitive behavioral therapies, the counseling, the physiotherapy, yoga, all these have to be. The drug of choice would be obviously pregabalin is the drug of choice, the first drug of choice. The second drug is duloxetine, and third is milnacipran. These are three drugs which have been approved by FDA. Milnacipran is currently not available in India, but duloxetine and this. So you have to weigh the symptom. If you find on your assessment that patient has a lot of cognitive deficit like depression, start with duloxetine. But if you think that patient does not have a lot of cognitive dysfunction, start with pregabalin. And gradually increase the dose depending upon patient's work schedule, job, and other things. So not that drug alone, you have to give other drugs also. So it is not just one drug treatment. You have to give other drugs like a muscle relaxant, tramadol, paracetamol combinations. So same is true with dysfunctional pain syndrome because fibromyalgia is one good example of dysfunctional pain syndrome, which have to be managed by multimodality and multidisciplinary approach, which involves counseling, CBTs, medications, exercises, yoga, and so on and so forth.
So next, Dr. Kulkarni says, could be that localized microtissue environment reacts as pain to accumulation of dologenic substrate due to relative stasis or mitochondria inertia. My hypothesis. Any comment on that, sir?
Well, to a certain extent, yes. So there is accumulation of tolerogenic substrates like these amines, the factors which are released in response to inflammation. But these are more relevant for an inflammatory type of pain or a nociceptive type of pain. This sort of a localized microtissue environment, I cannot per- perceive in a patient with neuropathic pain or dysfunctional pain. Maybe, yes, post trauma, maybe in a osteoarthritis, inflammatory pain. Yes, I can agree that perhaps there is a stasis and this causes a persistent pain. But again, very important thing is this stasis can lead on to a sensitization process. So the amount of these stimulating means accumulating causes the opening up of the NMD receptors. See, if that's why it is very important that acute pain has to be aggressively treated. If you don't treat acute pain aggressively, you'll have these amines increasing in volume at that particular level, which will open up the NMD receptors, and that will lead to chronic pain.
So next, Dr. Majumdar is asking, what is more beneficial in chronic pain management, drug therapy or non-pharmacological measures like physiotherapy and other forms of rehabilitation?
See, basically, again depends on your assessment of pain. If you think that it's a very severe, like a VAS score of 8, 10, drug therapies are important. Or if you think that there is something which can respond, like a neuropathic component, yes, definitely. But I would not say that drug therapy or physiotherapy in separately. I would rather combine. Drug therapy alone cannot work, and physiotherapy alone cannot work in the early stages. So once the VAS score goes down, then of course these measures like physiotherapy and other forms of rehabilitation are very, very important. That's why I was laying the stress all the time that don't think that giving a pain clear is the end of the pain. It is your rehabilitation, it is your making fit the patient for going to his work and for social activities, which is important. And that will come through physiotherapy and rehabilitation, for sure. But I cannot sort of do an understatement by saying, no, no, drug therapy is not required. That is also important.
So next, Dr. Ravindra is asking about acupuncture therapy for management of pain. If you could kindly enlighten about the mode of action at the site of lesion.
See, acupuncture therapy sort of has been a Chinese sort of a therapy, and in fact, I have used it almost in 1980. It was part of my thesis study rather, and that time it was in a lot of fashion because we didn't have these drugs like SNRIs or gabapentinoid, and it was like it was believed that there is a release of endorphins when you do the needling, or there is a yin and yang theory of Chinese which says that there are some opposite forces, which I generally don't believe. That I generally just believe that if you put it in a muscle, there is a release of endorphins and enkephalins, which causes relief of pain. But now it is coming in a different fashion now. We call it as a dry needling. Dry needling is putting needles in an area of muscle spasm to relieve spasm. But again, the hypothesis is same that there is a release of neurotransmitters when you put some needles in the muscles, and that relaxes the muscles and that gives relief in pain. So, I mean, of course, like chronic migraine and sciatica in the past, when we did not have much therapies available to us, we were using acupuncture, but we do not have any evidence-based studies till now to suggest that acupuncture works. So the modern medicine depends on evidences, and evidence-based medicine is the main source of our management strategies. So that is not available. So a lot of research is required to find out whether acupuncture can be useful. But yes, there are people who are using it with success.
So next, Dr. Patel is asking, so which is better for pain management, SSRI, SNRI, or a combination of both?
So it all depends on the type of neuropathic pain. These are generally used for neuropathic and dysfunctional pain. So as I mentioned in the past, in the few questions before this, that if it is like a patient who has got a lot of depression and anxiety, I would prefer with duloxetine. But if the patient doesn't have much depression, anxiety, I can use SNRIs and other drugs too. So it is not a preferred. I mean, like what drug I will prefer. It depends on the type of neuropathic pain, the symptoms of neuropathic pain, associated comorbidities, associative cognitive deficit, in which I will choose SSRIs and SNRIs. Of course, I will also go by the age of the patient. SNRIs can cause various deficits in elderly patients. So those things also I will consider, not just my choice for one group of patients.
Next, Dr. Shivam is asking, sir, can any radiofrequency treatment of superior hypogastric plexus can be done for idiopathic chronic lower abdominal pain syndrome for long-lasting relief in which diagnostic superior hypogastric plexus block has given good relief?
So, Dr. Shivam, yes, your patient has had a good relief. He deserves a permanent block. Radio frequency is one modality which you can use, but since it's a very sort of a complex plexus, it is not just one or two fibers. And radio frequency ablation is about 5 to 10 mm. So once you put the needle in the superior hypogastric plexus, you will be able to get a 5 lesion. So which may spare some of these nerves. So in my practice, I would prefer to use a neurolytic agent like alcohol or phenol, maybe alcohol, 50% alcohol, maybe, because the volume will sort of destroy all the plexus fibers. And if you do radio frequency, the lesioning will be 5. You can do at multiple places, but you can still sort of miss few fibers. So I would prefer in my practice 50% alcohol over radio frequency, but yes, theoretically it can be used.
So, with all the questions, we have some really great comments from our doctors. One such comment from Dr. Sunil says, thank you for speaking my heart out. This is the one and only future of medicine. Learn, incorporate, and practice. So, moving on to the next question. So, the other
Dr.
one says,
Dr.
the role
Podal
of
is
text.
from
Yeah.
Dr. Podal is from Nepal. Okay.
So,
Yeah, yeah.
moving on to the next question, role of dextrose as regenerative therapy.
Well, there are studies of using dextrose as what we call it as a prolotherapy. Again, as I said, there are evidences being generated, but yes, prolotherapy is helpful, and maybe it has some role in the future as a regenerative medicine. But as I again said, we don't have exact evidences, but yes, a lot of studies are being done, and it may find its use in some of the regenerative, like regeneration of the cartilage or ACLs or medial meniscal. It may find a role, but at the moment, it is still being researched and being used clinically too.
So the next question from Dr. Thomas, which is better, pregabalin or gabapentin for neurological pain?
Well, it can be anything. You know, I always, a lot of people ask me, and I say it's your choice, my choice, whichever drug. Theoretically, pregabalin, yes, because it's a alpha two ligand, and it directly goes and attaches to the alpha two ligand receptor, and it should provide a immediate effect. Gabapentin also metabolizes and then attaches. So theoretically, yes, pregabalin, but in practice, we can't give a full dose on day one. So we have to sort of start with a lower dose and gradually build up. So both the drugs will show effect in almost similar duration. So it's based on your experience. Like I've been using gabapentin for 25 years, and I've been using pregabalin for 20 years. More experience with gabapentin, seen the side effect profile, found nothing. So I prefer gabapentin, but not really. If it's an acute reticular pain, I could give pregabalin too. So it's your choice. I think there is no theoretical differences between the two drugs. Your choice. If you find any drug safe, use it. There is no recommendation on that.
So we've had some requests from some doctors that if they can ask their questions by themselves. So
Yes,
doctors,
yes,
definitely, we do encourage you to come on the
yes,
stage and ask your
yes.
question.
I
So
would
there is
welcome.
a feature on the app called as raise hands. So you just have to click on raise hands and I'll approve the request and you can come on stage and ask it yourself. So till then we can move on to the next question. Doctors, you can use the features raise hand. Yeah. Uh, so Dr. Gulam next says, can carbamazepine help in post-herpetic?
Well, yes, carbamazepine, although is a preferred drug for trigeminal neuralgia, but yes, we have had good experiences with this drug. Although you have to be careful about the side effect like the rash and all, but yes, definitely, Dr. Mohiddin, it can help in herpetic neuralgia too. We can use it. We should use it rather.
So Dr. Kamalkar, I have accepted your request. You can turn on your audio video and come on the stage, please. Yeah.
Sir, good evening, sir.
I want
Sir,
to see
nice
your
talk,
face
sir.
also. Can I see your face too?
Yes, sir. Yeah,
Yeah. Okay. Anyway, continue. Put the video on,
sir.
or just continue.
Yes,
Continue.
sir. Yes, sir. Sir, actually, how to manage this post-amputation phantom limb pain?
Yeah, that's one of the most difficult. I mean, I would confess that I have not been able to fulfill my duty as a pain physician in this particular syndrome because post amputation phantom limb or post amputation stump pain are the most difficult entities, I think, in our specialty to manage. We are still not aware of the cause of post amputation pain. Earlier, we thought it's a neuropathic pain because of the nerve cutting, but then we realized it's a sympathetically mediated pain. We started doing sympathetic plexus block, and finally, we realized that it's a dysfunctional pain. It's a nociplastic pain, and we know that nociplastic pain is the most difficult. So, in my experience, I've used spinal cord stimulator to some success. Some patients did get some success. I have put in a morphine pump too in a patient who had good relief with morphine, intrathecal morphine. But routinely we do stellate ganglion block. We do different. I mean, like the radio frequency ablation of the stump nerves or even the peripheral nerves, like the brachial plexus nerve in a hand, lumbar sympathectomy for lower limb. So it's like your experience which will help you, but you have to use different modalities. Drugs which act on the brain, ketamine infusions. We have used ketamine infusions too. So I can't generalize and tell you one modality, but depends on patient. So it's a step-ladder approach, starting with the basic drugs, then opioids sometimes, then sympathetic plexus block, then as I said, radio frequency ablation of the dorsal cord or the dorsal horn, and then finally moving on to putting in spinal cord stimulator devices, and then of course intravenous ketamine infusion. So it is a complex management schedule.
Sir, one more question, sir. Sir, what is the duration for this neuropathic pain in discogenic conditions? How long will you give pregabalin?
3 months minimum, sometimes more than that, but 3 months definitely minimum. So if a
When to
patient has
escal
if he has a
when
neuropathic, yeah.
when to escalate the dose from 75 to
So we
150?
have a schedule like first day 75, after 3 days 75 twice a day, after 7 days 75 150, after 12 days maybe 150 150. So we stop at 150 150 in most of the patients.
Thank you, sir. Nice, sir. Thank you.
Thank you, Dr. Kamal. If someone else wants to try this, definitely we do encourage you to click on the raise hand feature. Till then, we can go on to the next question. So Dr. Mohit says, how many sessions of ozone can be given in this bulge?
Well, initially, when we started this about 25 years ago, we were giving multiple sessions. But I mean, as I said, that disease, disc is a sort of a temple where you should not, I mean, like there are chances of infection, etc. So now we do only one, I mean, my team, we do only one session of ozone and stop it at that. Multiple sessions we tend to avoid. So my experience one, but there are like recommendations of 2, 3 sessions also, 5 sessions also. But I respect disc and I don't want to enter the disc unnecessarily and multiple number of times. So one session would be good enough.
Next, Dr. Rangwala says, local application of gabapentin and xylocaine on sole for diabetic neuropathy. What is your take?
Well, see, like any other ointment, like which we use for joint pain, the diclofenac gels and all, very. I mean, we haven't seen much absorption of the drug through the intact skin. So similar is the case with these drugs. I mean, like you can't expect lidocaine gel to go from an intact skin into the nociceptors, which are deep inside. Maybe more of a placebo therapy, but we do give, and some of the patients do respond. But if you ask me, like every patient responds, no, it is not like that. So maybe an application of a cool gel gives a placebo therapy more than a definitive therapy. So I would not theoretically be able to explain that these gels can percolate from an intact skin to the nociceptors and give local anesthetic or local reaction to this. So I would not sort of be able to give a perfect answer. But yes, you can use it. It does have placebo therapy. So why if anything which helps can be done, but can't explain scientifically whether these are useful.
So Dr. Ranjit, you can come on the stage and ask the question. You can turn on your audio and video, Dr. Ranjit. Okay. Till Dr. Ranjit comes, maybe we can move on.
Yeah, good evening, sir. Sir, good evening, sir.
Good evening. Good evening.
Yeah, sir. Sir, my brother is having leg pain, sir. Hello.
Yeah, we can hear you.
Yeah, my brother is having lower limb pain, sir, with walking. Those pains are comparatively more when compared to previous 1 year of walking, sir. So he had the history of anterior cervical discectomy and fusion at the level of C5, C6 5 years back. He has severe vitamin D deficiency, about 10.5 nanograms per ml, sir. So what will be the approach, sir, for him?
So do you? I mean, like I haven't examined the patient. Do you think this leg pain is because of the cervical myelopathy?
No, I mean, sometimes whenever there is cervical canal stenosis,
Yeah.
there are some chances of radiculopathy or muscle pains also. I have that doubt.
No, sir. It is cervical myelopathy. Which you said lower limbs, no?
Lower limbs only.
Yeah, lower limbs it happens because of myelopathy, not the root canal. Root canal will cause the canal stenosis will cause pain in the upper extremity and in the hand. But if it is a myelopathy, then yes, definitely legs can be affected. I mean, the gait can change, and it will be a waddling type of a gait. If that is the case, it's a myelopathy.
No other symptoms, sir, except muscle pains, not bone pains also.
No, I can
Only
agree.
muscle pains.
But with a history of cervical fusion and some spinal cord compression, which he had earlier, and because of that, it could be because of spinal cord myelopathy with myelomalacia or myelopathy, which could be causing. So important to give some muscle relaxants, which can help like baclofen. Very important to give pregabalin or gabapentin, and then you can sort of combine for a short duration tramadol paracetamol combination. So these three can really help your brother.
Okay, sir. So he is also having with severe vitamin D deficiency.
That you can correct by giving an injection of vitamin D. Just one injection should be sufficient.
For 8 weeks, sir. 8 weeks.
No, only one injection, and then follow it up with oral 60,000 units per week
60,000 per week for 8 weeks, sir.
for 8 weeks. Yes.
Okay, sir. Okay. Thank you, sir.
Thank you.
So moving on to the next question. It is from Dr. Swati. Is duloxetine safe in fatty liver?
Well, yes, duloxetine is more or less safe in fatty liver. It depends on the grade of fatty liver. Fatty liver 1 and 2, it is pretty much safe. But you have to monitor the liver functions. So you have to keep a watch on the liver functions like SGOT, alkaline phosphatase, every month when you are putting the patient on long-term duloxetine. Short-term duloxetine doesn't make much of a difference. So just fatty liver is not a contraindication. It is the liver dysfunction which can be contraindication.
Next, Dr. Purohit is saying, so for osteoarthritis pain, we cannot prescribe NSAIDs for a long time. Same is for chikungunya pain. So what are the drugs that can give sufficient relief? Also, can we use Ayurvedic drugs?
Well, that is the most important thing. That osteoarthritis, at one stage, you will not be able to manage with these painkillers, and you can't give NSAID for a long time. Most of the recommendations says 2 or 3 weeks. You can keep rotating, but not more than a month that you can give NSAID. And in vulnerable patient, even 1 month is more than required. So yes, we are using high doses of paracetamol. So we have 1 gram tablet which we use 3 or 4 times a day for managing this. We can use tramadol paracetamol combination. You can use tapentadol also. These three drugs can give relief, but they're not anti-inflammatory drugs. So that's why you have to combine other modalities like intraarticular injection, or you can use these tenicular nerve blocks for giving relief. Even the same is case with chikungunya. You have to give specific drugs. It's a reactive arthritis, so you have to give drugs like HCQS, hydroxychloroquine, and combine it with drugs like acetaminophen 1 gram 3 or 4 times a day, and use paracetamol local application. But yes, you cannot give NSAIDs for a longer period. Ayurvedic drug, I don't have much experience, but Ayurvedic drugs like given by these quacks have steroids, so you have to be careful about using Ayurvedic drugs.
Uh, so next, Dr. Sahitya says, want to know about the response of spine PRP therapy for discogenic pain. If effective, how many sessions do you suggest? Also, how much ml should be given into this? And is there any role of facet joint arthropathy?
Dr. Saitya, I think he appears to be a pain physician because he's asking very specific questions. Yes, we have been doing this PRP in discogenic pain, and yesterday itself we did one case, and we used PRP 3 sittings. And my experience is 15 days apart, 3 sittings, and you will not be able to inject more than zero point 0.6 to zero point 0.8 ml of PRP with growth factor, which we use, and 3 sittings, 15 days apart. That is what we use, and as I said, not more than 6.8 ml will be going into the disc. If you use larger volume, there's a tendency for you to rupture the annulus, which you should not do. And you said about facet joint, similar. Facet joint we have been doing for last maybe 2-3 years, and instead of doing a medial branch radio frequency, we thought that we must regenerate. We started using it, and we have got again. At that particular time, we were using it at monthly interval, but now our protocol is 15 days apart, 3 sessions for facet joint, and similarly 3 sessions for discogenic pain.
Next from Dr. Verma, pregabalin and gabapentin often causes dizziness to patients. How do we tackle that?
It is not often, it always causes dizziness. I mean, you will have to be a superhuman being if you don't have a dizziness with gabapentin. I mean, like pregabalin. Gabapentin, there are people who don't develop dizziness. So that's why always start low and go slow. That is the thing which we always tell the doctors. So start with a night dose. And if you're giving it to an elderly patient, please tell one of the family members to sleep with that patient that night, because if she gets up to go to the bathroom, she may not fall. So the dizziness will always be there. So start with lowest dose, like elderly patient 100 milligram of gabapentin or 50 milligrams of pregabalin. Next night you see the response and go to 200 and gradually build it up. So start with night dose. After 4-5 days, make it morning and night dose, and that's how you escalate the dose.
So Dr. Anand is asking, is there any multidisciplinary center in India or Asia?
Dr. Premanand, okay, from Chennai. Dr. Prem, yes, we do not have our infrastructure. We don't allow us to have a multidisciplinary center in India, and obviously Asia. Forget it. We are the best in Asia. So South Asia or Southeast Asia, no country has anything better than what we have in India. Maybe Japan, I am not sure. Japan may be having. Korea, I've been there. Korea does have a couple of centers which are multidisciplinary. But India, well, like if you are like in a big institution, but like when you say multidisciplinary, all specialists sitting together, Asia, for sure.
So there's still a lot of questions. Would you like to take a few more?
If you are okay, I mean, like I'm questions.
Yeah, few more. Okay.
Yeah.
Uh, Next from Dr. Saif, what is the role of steroid injections in osteoarthritis?
Well, we have a grading of osteoarthritis. So get an X-ray standing position and grade the patient before you plan. Grade 1, definitely there is a good role of steroid injection, but definitely not repetitive. Once in a year. Once a year is the maximum injection you can give. And mostly use not particulate steroids, combined with local anesthetic, and give it. Right? There will be relief, but the relief in grade 1 can last for years together. Like we have patients in grade 1 who have had relief for 5 years, 7 years. That is grade 1. But if it is grade 2, I mean, like the response may not be as good as in grade 1. So steroids do have a role in grade 2 along with other modalities, but the response will be 3 to 6 months. So you can combine hyaluronic acid with that. Even in grade 1, you can combine sodium hyaluronate with them. That prolongs the effect of the steroid. But as I said, now is the time when in grade 1 I would rather prefer to do a stem cell or PRP for such patients. Steroids can be done, but remember, not more than one injection in a year. If you want to preserve the joint, don't want to cause more damage to the joint.
Uh, Next from Dr. Hussain, any role of calcium supplement in chronic pain?
Well, I would not say that osteoporosis itself causes pain, but yes, calcium has a role. I mean, like if your patient is osteoporotic, then he may have pain because of degeneration of the joints, etc. So calcium itself does not prevent osteoporosis or osteopenia, but calcium is an important component. But of course, you have to combine with vitamin D because that's an important part of calcium metabolism. You have to give other drugs like the ibandronate and the other drugs which have to be combined with it. So calcium per se will not help in chronic pain, but as a cause of osteopenia and other modalities, it may help a little bit. There are other elements which can be useful, like magnesium, the phosphates. They are very useful, and they rather help with chronic pain much better than calcium.
Next question from Dr. Shivam says, regarding the previous question about the radiofrequency treatment for the superior hypoglycemic plexus block, sir, is there any contradiction in patient who is about to conceive? Though theoretically it will only be sympathetic blockade.
Not really. Not really, but yes, this is a very intelligent question. Conceive and then deliver also. So, and uterus, etc. So, can be safely given. So, not much of a problem. The patient hasn't conceived. He's about to conceive. I don't know how he knows he's about to conceive. But yes, if the patient says, yes, I want to conceive, but I have pain, then you should have definitely treat it with superior hypogastric plexus. Once you have done it, then you tell the patient, okay, you can go ahead for conception.
Uh, Dr. Kamble asks, treatment for periodical paralysis.
What is that periodical paralysis? I don't understand. Periodical paralysis, is it? I don't know. I have no no knowledge about what is periodical paralysis.
Okay,
Anyway, next.
maybe we can take another question. Dr. Ranajit, role of microglobulin in neuropathic pain as it is available in Bangladesh.
Well, miroglobulin as such is not yet available in India. If it is available in Bangladesh, you can use it. There is plenty of studies in the literature about miroglobulin, and almost similar results what we get with pregabalin and this thing, but minus some of the side effects like less dizziness, less weight gain, which is seen with miroglobulin, and the onset of effect is also much faster than pregabalin. So miroglobulin can be used. We are waiting for it to come in India. I think within next couple of months we will be having this in India too.
So there's still a lot of questions that are coming in, but I would request our doctors if it is okay for me to pass along the questions to sir, and then sir can answer according to his convenience, as it is already past 10 and sir has already answered a lot of questions in this live session. We'd really appreciate your understanding, and I'll definitely pass along your questions to sir, and sir can answer them according to his convenience. So, with this, we've come to the end of this session, and thank you once again, sir, for this wonderful, wonderful session. I'm really confident that our doctors have really loved it. We have 400 plus live attendees,
Yeah.
and thank you so much for this, sir. It was really lovely to have you with us, and hoping to
Thank
see
you.
more of you, sir. Thank you
Thank you
so
so
much,
much.
sir.
Thank you. Thank you so much.